In chapter 68, we're just going to be covering part of it. I had said to start on page 1431 at renal replacement therapy, but realized I need to discuss a little bit about chronic kidney disease. So we're going back to page 1415, and I'm going to touch on what parts you need to understand here. I also uploaded some things on just the basics of chronic kidney disease, a little video on that, and the 5 stages of kidney disease from some YouTube videos. So chronic kidney disease is progressive, irreversible, unlike acute kidney disease, which is reversible. Chronic goes through 5 stages, the 5th being the end stage kidney disease. It's not reversible. They go on dialysis and await a transplant, hopefully get a transplant. Correct myself again, page 1419, not page 1415, where it starts to talk about chronic kidney disease. So the electrolyte changes, you're on page 1419. It has a chart that goes through the 5 stages, and I said I also uploaded a video that goes on the 5 stages. And when you're on dialysis, you're in that end stage kidney disease, or ESKD. All your stages go by your glomerular filtration rate, or GFR. And you can see it's a GFR of less than 15th is the 5th stage or end stage. Nobody goes from 1 to 5 without going through each stage. Multiple things can cause it, the damage to spread with infection, inflammation, pregnancy, dehydration, severe prolonged hypotension, and then chronic hypertension. The metabolic and electrolyte changes are listed on page 1420. You should be familiar with these. Just a really quick review with your urea and creatinine excretion. Because of your kidney failure, that is totally disrupted. Your creatinine comes from your protein in your skeletal muscles. And so and your urea is made from protein metabolism. Both should be excreted from the kidneys, so of course those are increasing as the kidney does not filter anymore. When you're in the final 5th stage of kidney disease, you also cannot, or you have a decrease in your excretion of your sodium, resulting in hypernatremia, also hyperkalemia with your potassium. Your acid-base balance can be off because your kidneys are having trouble excreting. The body can no longer reabsorb the bicarb, and it leads to a buildup of the hydrogen. And then they have the elevated potassium levels, and they end up with an acid retention, metabolic acidosis, and on from there. Your calcium phosphorus, I don't know if you remember, we talked about in pediatrics that they take a phosphate binding. Calcium and phosphorus is you excrete one, you retain the other. And in chronic renal disease, or end-stage renal disease, they're not able to excrete that phosphorus, and so the phosphorus is up and the calcium is down, so they take medicines to bind the phosphate so they can excrete it. And a lot of times calcium is monitored and they get some calcitonin or something, usually during dialysis, when the measures are taken and they need their calcium replacement. Page 1421 starts going over the different changes that are taking place. The hypertension is very, very common because when the kidneys fail, the renin-angiotensin cycle is all messed up. Often a person has hypertension that has damaged the kidneys, and then the hypertension is worse with the kidney failure. Hyperlipidemia, elevated lipid levels, because they cannot break down, their fat metabolism has changed and leading to an increase in their lipid levels. Heart failure because they have a lot of fluid retention, fluid overload, and hypertension that affects the heart pump, leading to higher pressures and right and left-sided heart failure. Pericarditis is another risk, again because they have all these uremic toxins that building up, and they have cardiac issues. The pericarditis can result for this, and it can even result in a tamponade and death. Hematologic changes, a chronic renal disease patient has a chronic anemia due to their kidney problems. The kidney produces erythropoietin for your red blood cell production, and with the kidney failure they're not able to do that. Again, they usually receive erythropoietin while they're on dialysis. It's administered during that time. GI issues, anorexia, nausea, vomiting, a lot of ulcer disease, but they have to be careful with what medications they take for their ulcers because of the phosphate issue, and also they cannot excrete magnesium, so they cannot take antacids or things that contain either of those. And now we're going to skip on over to page 1423. There's a table or chart. 68.4 does an excellent job of breaking down all of the assessments, systematic assessment for these clinical manifestations. Neurologically, there is an awful lot of fatigue, lack of energy, maybe some tremors, paresthesia, which is the tingling or numbness in the extremities, cardiovascular, cardiomyopathy, hypertension, a lot of peripheral edema, possible heart failure, pericardial effusion. So if you're thinking of doing your assessments, you want to do a really good neurological check. Cardiovascular, you'll definitely listen to the heart sounds. You listen for pericardial friction rubs, gallops, irregular rhythms, pericardial friction rub because you're looking for a possible cardiac tamponade. That's the pericardial friction rub you will hear with the actual heart beat, with the heart sounds, and it sounds like a leather. You can distinguish from the pleural effusion or the pleural rub because the pleural rub is heard with inspiration and expiration, whereas the pericardial friction rub is actually heard with the heart sounds, and it sounds more like a leather. Okay, so onto the respiratory. Tachypnea, you might see the cosmal respirations because of the metabolic acidosis. There's a good chance of pulmonary edema. You're checking for JVD and crackles. They may have some chest x-rays to show this fluid buildup. Hematological, of course, the anemia, possible decrease in platelet counts. So you're watching for bruising, chances of bleeding. GI, we covered the nausea, vomiting. Often have a metallic taste in their mouth. That's due to their uremic buildup because they can't excrete it. They can have this uremic colitis that causes a terrible diarrhea. The gastritis, again, the bleeding ulcers are due to the uremia. Urinary manifestations. Most people in end-stage renal disease do not urinate. They have anuria. Some are oliguria, which is just very decreased urine output, but they still could for a time, excrete as much as 1 liter per day, but they will be underneath that. On their skin, they get this dry yellowing. Uremia causes a frost, what they refer to as uremic frost, and they get yellow and brown on their skin. Musculoskeletal, because of the calcium phosphorus issues, they can have bone pain and fractures. Yeah, that covers that. Hemodialysis. On page, I thought I paused it. I apologize there for just not speaking for a few minutes. Hemodialysis, I was trying to find the page. Page 1431, that's where we're going to go right down to the renal replacement therapies. This is for the end stage or stage 5. There's a table 6810, comparison of hemodialysis and peritoneal dialysis. Look over that so you can understand the difference in what you're looking for and possible complications. Hemodialysis is done through the blood. Peritoneal dialysis is done through the peritoneum. So on hemodialysis is the most commonly used. There was a long period of time there when they were promoting more peritoneal dialysis, and I think they're going back the other way back to hemodialysis. So the patient for hemodialysis, sometimes I've seen temporary dialysis go on when they're more at a stage 4, just when their fluid overload is so extreme. They have pericarditis, hyperkalemia, lots of other problems, and they may put them on a temporary dialysis to relieve it, and that does not mean it's going to be a chronic, so they may have that before they actually reach the end stage. So it's not only stage 5 that gets dialysis, but our focus is going to be more on the stage 5. Dialysis settings. When they are hooked up to the machine, when they come in for dialysis, the next slide is the actual hemodialysis circuit kind of picture of it. It's hard to explain this without having things here to show you. But anyway, there is, I should have put a picture in here. Oh, there's a picture in your text, 1432, of the artificial kidney that is used, that is put into the machine. If you're looking in your text on 1433, right next to it, you see a kidney dialysis machine, and you see that little artificial kidney sitting there. Of course, it is used for one treatment and discarded. Dialysis works with a diffusion where the blood never comes in contact with the fluids that are in the dialysate itself. It just, things cross over the barrier to pull in equilibrium. The amount of time, you usually have a set time. They're set to go on dialysis for hemodialysis for 3 hours or for 4 hours. When they come in, they're weighed, and it's calculated what their dry weight is to how much they gained, how much you need to pull off, and you set the machine to pull off so much an hour. Sometimes you can't pull all the fluid off because you're pulling so quickly, because they've gained way too much. They have not been obedient with their fluid restriction, and so you take off what you can. So the potassium sodium is moving out of their blood into the dialysate, and the bicarb calcium moves from the dialysate into the person, into the patient's plasma, trying to get them balanced. The procedure itself, I have a couple of one slide that's coming up where it shows you the different cannulas, fistulas. We're going to get to there. on where they hook it up. There's 2 needles that are put in, and I'll explain that when I get to those slides. The dialysate is warmed through the machine. There is, as far as anticoagulation, you don't give the anticoagulation directly to the patient. It is put into the machine to help prevent the clotting of the blood flowing through, but through the dialysate, some of the heparin does get into the patient, so they may have a bleeding issue. They have to be very careful for 4 to 6 hours until that heparin cycles through the body. That's just a picture of the circuit. The machine would be back here. Here's your artificial kidney, and you can see it hooks up to the patient. Or there is an arterial and a venous access. So the arterial is pumping out. It goes through the dialysate, trying to equalize as much as you can, and pumping back in for the venous return. The vascular access. It depends on whether it is going to be long-term or temporary. They use some hemodialysis catheter, dual, triple lumen, an AV shunt. The next slide will give you some pictures that I'm trying to see. I thought they had a picture in your text. I guess they don't have a picture in your text of those catheters. Well, the next slide is those catheters that are used temporarily, and then I also have a picture of a fistula versus a graft, which are long-term. Fistula is preferred. They last a lot longer. Just notice this got clinical judgment challenge on the bottom of page 1435, talking about fistula and the patient getting ready for it, the kind of teaching you're going to do, and care priorities for the patient. So that's pretty good down there, that you might want to look over that. Let's see. There, look at that box on chart 68.7. Complications with the access is infection, well, most commonly staph, because Staphylococcus aureus lives on our skin. So when you're coming in 3 times a week and these being accessed on any vascular access, especially with the needles, that there is always a chance of infection, even though the skin is cleaned very well. Aneurysm, because you're puncturing that same site, and I probably should have put the picture of the access before these, but there is a picture in your text just above there, and when you keep accessing and accessing, there is a chance of forming an aneurysm and having to get repaired or a new graft or fistula put in. Ischemia is not that common, but it can happen where there's a decreased blood flow in the fistula, which they call a Steele syndrome, and it's where they get a cold numbness in their fingers. You need to assess anytime somebody comes in for a dialysis, or if you get a patient, you might have a patient that has a graft or a fistula. Even if you are not doing dialysis, if they have one, you need to be listening for you probably had an opportunity to put your stethoscope on it and you document that you hear a good bruit. If there's not a bruit, it could be a clot in it. If anybody with a graft or a fistula is saying their hand is numb, if you notice the hand is cool, that is something to report because of this Steele syndrome, and you don't want their fingers without circulation and causing gangrene. Okay. So let's move on to the next one. These are some pictures of different subclavian catheters, temporary catheters that can be put in. Sometimes they're temporary. Sometimes I've had many years ago when I did dialysis, I had a patient that was HIV positive. It was from IV drug use. So she had one of these put in to decrease the chances of risk for personnel, healthcare personnel, so that we did not have those big needles we were putting in the arm and coming in contact with her blood. So decrease that risk. She had one of these put in, even though she was end stage on a dialysis 3 times a week. This is some pictures I found, the AV fistula, and this is a picture of an actual fistula. This is the AV graft, and you can see how it is. The grafts don't last as long. These, they use the person's vessels. They last much longer. One thing to know, if you went on internet and you look for pictures of some of these, you will see people with multiple up their arm because they don't last forever. And they have to get new ones in, and they'll go up the arm, up the arm, up the arm, on the other arm, and even some have to get down and using the thigh, and then sometimes they end up with a subclavian or something because they're out of sites if they've been on dialysis that long, or their grafts or fistulas just don't last. I talked about some of these access complications already. I talked about infection, thrombosis, stenosis, where you listen for the bruit, the aneurysm, ischemia, again checking that flow. Heart failure can happen just due, very, very rare, but just like the arterial flow from this can cause like a shunting and cause failure, but that's very rare. Hemodialysis nursing care. Drugs. Table 6813 on the top of the page, 1436 goes examples of drugs that are dialyzed. There are many drugs that will be pulled out from dialysis, so you need to clarify what drug needs to be held before dialysis and given after, so that you don't administer it and it's dialyzed out. I'm not going to ask you those specific drugs. There is something to kind of be familiar with and look over that. Post-dialysis assessment. Actually, you're doing it during dialysis. If you have a patient that leaves the floor for dialysis, or sometimes now they'll come in and they do dialysis in the room. Dialysis nurse will be in there monitoring things. They have hypotension, headache, nausea, vomiting, malaise, dizziness, muscle cramps, or bleeding. I remember those occurring while I was on dialysis. They have this, what they call, I think that's on the next slide. So in your nursing care, these are things you are watching for. These patients are always on daily weight, and they are on strict INO, fluid restrictions, sodium restrictions, potassium restrictions. Okay. Complications of hemodialysis. This dialysis disequilibrium syndrome you used to see quite often, but it was that I haven't done dialysis for the last probably over maybe 20 years ago, so that was a problem we had, and I see that they're saying it's not such a problem any longer because of the newer machines and the way they pull the fluid off, because we used to pull quite a lot off and caused these problems where they would cramp, they'd get sometimes pass out on you. It was terrible, this vomiting and headaches. Infectious disease, hepatitis B, C, HIV, really don't see those as so high risk as far as a patient getting them from the procedures. It's more the healthcare professional that is performing the procedures, because of the needles and the excessive blood exposure, that would be more at risk. And you do need to watch for bleeding after the procedures. Okay, peritoneal dialysis. The catheter is placed permanently for an extended period of time. If this is the only dialysis they're going to receive, then it's pretty much a permanent. They use more of the peritoneal on children. Sometimes peritoneal dialysis is the temporary dialysis that's administered in the hospital. There are advantages and disadvantages of doing peritoneal dialysis. It is slower than hemodialysis, so they can't pull off as much. They lose more protein this way. There's a higher chance of infection and a peritonitis doing it through the abdomen. That's listed in 6810 of your text. Is a chart that compares the good and the bad of both. Who gets peritoneal dialysis? Usually those that you cannot tolerate any anticoagulant, but you need to put in for the keeping vascular access in the hemodialysis. Also, if sometimes they're doing it temporarily when it's an end stage and they've lost their access site, it's infected, it's got a clot, there's something going on, and they don't have another site yet, so they will do peritoneal dialysis or put in a temporary catheter. Some people cannot get peritoneal dialysis because they've had abdominal surgeries or other problems where they can't be able to use the peritoneal cavity for that filtering. When they're dialyzed through the peritoneum, the solutions are selected depending on how much sodium or what they need to pull off just from the peritoneal cavity. The peritoneum is very vascular. It has a lot of capillaries. That's why the exchange is able to take place through the peritoneum. There's different types. The continuous ambulatory, automated, intermittent, and continuous cycle that's used for different reasons. And the next few slides are just like from the pictures in the textbook and go over the different kinds. Peritoneal dialysis exchange. Not sure how much you'll see this anymore. It may be for a very temporary dialysis or an acute need for dialysis. We used to actually do this in the hospital back in the 80s. Actually, we would perform, all the nurses in critical care had to perform this type of dialysis exchange. Then there's the continuous ambulatory peritoneal dialysis, which is exactly what the title says it is. That it's while they're walking around, they are being dialyzed. It's just like the other where you hang it, you dwell it. This one's continuous. Let me go back. On here, it goes in and you clamp this off, and let it dwell for a certain period of time, whatever's prescribed. And then you unclamp and let it drain, and then disconnect. And when the next change comes place, the same thing. You hang this, you clamp so it doesn't drain, you let it go in, you let it dwell, and then you let it drain. Continuous is continuous. It's not certain periods of dwell. This is a continuous thing that's going on. Automated peritoneal dialysis. There, don't show the peritoneal dialysis machine, but there is, I think it's in your text, there's a little one that they can use at home. They have some in the hospital too. For automated peritoneal dialysis, the machine is set. They will use this in the home where it is set to cycle a certain amount, certain time. All the settings are in there. The patient can easily be taught how to hook up to the machine, and it dialyzes. So some people are set where it does it all night. Sometimes it does it a couple times a day for a certain period of time. Complications. Peritonitis is the hugest. They shouldn't have a lot of pain. There may be something wrong. You are assessing for that. You're always assessing for infection, tunnel infections. That's where the pain would be at the exit site or the catheter site. If the flow is bad, there could be a problem. Dialysate leakage can happen into the peritoneal cavity. This leakage usually occurs when they first started do the peritoneal dialysis, so they start at a slower rate, and as the patient tolerates, and then increase in leakage should stop. There could be a bowel perforation, so you're watching for constipation, which may have affected the flow, so doing thorough assessments for that, looking for any brown or colored discharge coming from the exudate, knowing that there might be a bowel perforation there. Nursing care for peritoneal dialysis, we are almost done. Again, the weight before the treatment, comparing to their dry weight, doing your vital signs. Your labs are the same for any kidney renal patient. Respiratory distress, pain, discomfort, looking for complications, looking for leakage, looking for infection, looking for poor flow, making sure when you're draining out that it is lower than the abdomen. Kidney transplant. Kidney failure is kidney failure. Getting a transplant is not a cure, as the transplants have become much more common than they were in the early 90s when I did hemodialysis. Back then, people just really they were on dialysis 6, 7, 8, maybe 10 years before they died. It was rare that anybody got a transplant back then. Now it's much more common, but they were very rare, and unfortunately we didn't have a lot of the knowledge and the drugs we have now to prevent rejection. Well, the rejection drugs, so people would leave for 6 months and reject and be back on dialysis. But they're doing much better now. It says in your text, 17,000 to 18,000 kidney transplants are performed yearly in the United States, which is excellent. But there's still 159,000 people waiting for transplants. But the average wait time, 678 days, which is 2.5, 3 years, much better than it used to be. So who can get it? They're trying to get, it says the average is between age 2 all the way to age 70. It depends on their health status, their ability to, their chances, decreased chances of rejection, not having severe cardiac problems where they can't tolerate the transplant, or the drugs, the anti-rejection drugs, people that have psychological problems or problems with drug or alcohol problems, severe peptic ulcer disease, GI problems, and anything that's going to decrease their ability to tolerate this. Donors can be from the bloodline, related or not related. Just they even have, they call those living donors may or may not be related as long as they are a match. Non-heart beating donor I thought was interesting. That's where you do harvesting. Is when we would refer to them as dead on event, or DOVs. Everything dies, or they had a traumatic surgery, they're brain dead, but their organs are still functioning, and they can salvage those or harvest them. And then there's transplants from cadavers. They have to go through all the immunologic studies. I'm not going to go into the whole surgical procedures. I did put a picture on the next line to show you. It was just interesting on the way they do the procedure. So I put these two pictures here because I thought it was interesting. When you put the kidney transplant in, they have a picture in the text, but I thought this picture was better, so I put this in there instead of the one from the textbook, because they don't remove the non-working kidneys. They leave those alone, and they transplant down here in the pelvic cavity. They put it in. You can see here where they hook up the artery, to make a renal artery there, and they hook up the ureter right up to the bladder. I thought that was pretty cool. This is, it talked about having a laparoscopic donor nephrectomy, and I was trying to figure out how they did that. So you've probably been in OR with your rotation and seen where they use the laparoscopic, and they use a little tiny incision to pull the kidney that's going to be donated out. I just thought that was helpful to show you those pictures. Now we're going to our very last slide, our post-op care. Nursing care is just as it would be in any post-op, but you're specifically looking for signs of rejection and infection. Urologic management is essential. That's one of the things to make sure that their bladder and everything still works because they're going to have to, the bladder has to work again, so when their kidney is functioning, you want to assess the urine output hourly for at least the first 2 days or 48 hours. Looking for any clotting, obstruction, looking at the urine color, looking for clotting or bleeding. Sometimes they have to do some irrigation, continuous bladder irrigation. You're looking for the chances of urinary tract infection that may occur within the first few days after surgery. Looking for oliguria or decreased urine output because of ischemia or rejection. Strict INO, blood pressure vitals, monitoring their labs for their electrolyte balance, especially the sodium, potassium. Complications can be from rejection. There's 3 types of rejection: hyperacute, acute, and chronic. Acute is the most common. They try to give them more immunosuppressants to try to prevent rejection. Ischemia from delayed transplantation following harvesting can happen, may need dialysis until adequate urine output returns and the BUN and creatinine normalize. Thrombosis of the major renal blood vessels may occur during the first couple of days after transplant. You're again looking for that urine output. A sudden drop it is a sign that something's wrong. Renal artery stenosis may be due to their hypertension, because usually this person was hypertensive before the kidney disease and now they have severe hypertension that can hurt the new kidney. Just taking care of the surgical site, strict aseptic technique, because they also are on immunosuppressive therapy as part of their anti-rejection. And patients need to understand exactly how to take these drugs and stick to them to decrease the chances of rejection. Psychosocial preparation, that goes for both sides. The person receiving the kidney, they have something outside of themselves. They've also been in a pattern of having to do dialysis so many times a week. They haven't urinated in several years. It's things that seem common sense to us, but things that we have to help this patient work through. Also the person that was the donor, because they are also a patient, have had surgery and they've lost one of their organs. So there's a lot of psychosocial things that should be dealt with prior and then also followed afterwards to make sure they are working through all of this. And that is the end of this presentation. Thank you.